Good morning, and thank you for inviting me to speak in front of the ophthalmologist. I'm a rheumatologist, so it's a little bit unusual setting for me. And I will be talking today about combined uveitis clinic in Calgary, which we run with my colleagues, Dr. Fielden, Kirani, and Williams, and myself. So I'm presenting on behalf of our team. So those are my disclosures. So I just want to touch briefly as an introduction on utility of multidisciplinary team and the concept, its concept. So nowadays, providing quality medical care depends on a careful coordination between multiple treatments and treatment providers, and careful exchange of technical information and communication between different providers and specialties. And it does not always exist, or there's challenges in exchange of the information. And with increased complexity of the patient cases, we see more and more specialties and more providers are being involved in the care, and the potential for failure between different providers exists, and that failure sometimes can impede our quality of care. So the gaps in communication can result not only in patient-related outcome, but also can frustrate and feel unrewarding for the care providers. So they can cause delay in treatment planning and implementation, cause unnecessary duplication of tests and procedures, incomplete follow-up, increased anxiety and dissatisfaction on patients' part, and decline in quality of care, which can lead to complaints and even legal litigations. But as I said, it also can frustrate and feel very unrewarding for the team members, and it has been identified as a major risk factor leading to burnout and psychiatric morbidities on the part of the consultants and healthcare providers. So for the at least last 50 years, they've been introduced concept of multidisciplinary care team model, and it initially came in the field of oncology. So there was very complicated patients that are often being followed by multiple specialists and have been very demanding in terms of exchange of information between care providers. So the model has been tried in cancer care and then quickly moved to other areas of medicine, including pain clinics, musculoskeletal disorders, neurologic disorders, cardiovascular, and then mental health and women's health. And the whole model assumes engagement of multiple medical disciplines and medical specialists and close collaboration between those. Patient and patient family involvement is also a cornerstone of success for functioning of multidisciplinary team and essential for patient satisfaction. So it's really rewarding to see the function of the team, which they share the same goals and supportive of each other and exactly know the role of each other. So the team compositions can vary, and the names of the different teams can vary as well, but there are largely three different variants of teams. So one is multidisciplinary team that engage multiple specialties. We're talking about like physicians and consultants from different disciplines and different areas of medicine. For example, in oncology, there could be a combination of radiologists, surgeries, pathologists, radiologists, internal medicine, medical oncologists. But there's also composition of the team which can involve different specialties as well as allied health professionals, including nurses, physiotherapists, occupational therapists, and technicians. And of course, the most recent and form of multidisciplinary team is so-called integrative medicine, when conventional medicine is being combined with so-called complementary medical services, such as chiropractic, acupuncture, massage, mindfulness yoga, training or yoga. And those tend to gain momentum and be very popular. So other factors that can influence the performance of the team include the structural organization, settings, and defining the functional role of the team. So of course the organizational culture is very important. It's really beneficial to function in a setting which is very supportive of multidisciplinary team model, including hospitals and private settings. The composition of the team largely depends on where it's being focused on treatment of the particular disease or encompasses the whole continuum of the disease care. And the size also can vary depending on the complexity of presenting cases. The literature is very limited on how and when and who is supposed to organize those multidisciplinary teams. And there's no clear evidence of how it could be organized, implemented, assessed, and funded. So there's basically no comparison between traditional form of medical care compared to multidisciplinary team. However, there is evidence that collaborative work can increase can have its benefit, and it's the care given by group is greater than given by separate specialists, and their team can offer the rare skills and knowledge that could be used more appropriately in a team setting. It can avoid the duplication and gaps in teamwork, and peer influence and information learning can occur easier in a team setting. The job satisfaction and satisfaction of the patients go up, and it also can create a very creative environment and for interaction between subspecialties. So that was in a way of my introduction to my next part of my talk, where I'm gonna, and I hope I try to convince you that multidisciplinary team is an important model, and I'm gonna touch on our multidisciplinary team that we have in Calgary at the South Alberta Eye Center. So this clinic is being established in 2004, and I joined it in 2010. So we started to capture the information only very recently, so it might not be very complete information, but I'm going to share with you what we know about our clinic right now. So we serve South Alberta with the population roughly 2.5 million. And this clinic has 3 ophthalmologists, Dr. Kirani, Dr. Jeff Williams, and Dr. Michael Fielden, and me as a rheumatologist. We run more than 30 clinics per year and more than 500 visits per year. And it's usually, the patient referral is initiated by the ophthalmologist for 2 main reasons. It's either steroid-sparing immunosuppressant therapy or try to rule out systemic autoimmune disorder. So our database includes almost 450 patients that's been seen in a clinic, and there is female predominance amongst our patients, so 61% of the patients were females, and ages vary widely, and we have people as young as 9 years old and as old as 91 years old, saying that I'm an adult rheumatologist and I'm trying really hard not to get engaged in treatment of pediatric population. So those young patients are really outliers. And currently, we're looking right now at extending that clinic into the pediatric segment. So there might be a pediatric rheumatologist who will join our clinic and look after the patients with GIAs and uveitis. So more than half of those patients that have been seen in combined uveitis clinic actually have long-term follow-up, which more than 3 visits at the clinic. So if you look at exact diagnosis of the those patients, that quarter of them have anterior uveitis. 12% will have intermediate uveitis, almost 30% posterior, and almost 20% pan-uveitis. There is a significantly less number of patients who have scleritis or episcleritis, and a smaller number have retinal vasculitis or inflammatory orbital syndrome. We've had questions about anterior uveitis, why retinal surgeons are looking after patients with anterior uveitis, and that's simply because those cases are usually very complicated, and they either associated with underlying autoimmune disorders or they have significant ocular complications. So out of 116 patients with anterior uveitis, 22 had HLA-B27 positive disease, and 13 had underlying rheumatological or autoimmune conditions. 8 were associated with sarcoidosis, and in terms of complications, 30 of them had cataracts, 33 glaucoma, 29 CME, and some retinal detachments. So those are not very straightforward anterior uveitis cases. Looking at other diagnoses, intermediate uveitis also was, some of it was associated with sarcoidosis and rheumatological disorders. Posterior uveitis, which were 130 patients, usually represent a multifocal choroiditis or PIC. Some of it were birdshot, VKH, and a large proportion had rheumatological disorders. And panuveitis mostly was associated either with sarcoidosis or rheumatological diseases. So looking at complications, that's what we're trying to avoid, hopefully by close collaboration. But there's a still significant proportion of people who had already pre-existing or developed complications. So 24% had cataracts and glaucomas, 17% had CME, 15% epiretinal membrane or optic neuritis. There were 12% retinal detachment, and almost 40% had synechiae. So looking at the particular etiological entities, I already mentioned that most of those people would have either sarcoidosis, rheumatological diseases, but we also had rare entities and kind of more reportable cases, kind of one of the kind. So there have been autoimmune retinitis, Azur, Behçet's disease, frosted branch angiitis, IgG sclerosing disease, lymphoma, ocular myositis, retinitis pigmentosa, Stargardt's disease, sympathetic ophthalmia, Sussex disease, TB, TINU, and even uveitis that have been induced by TNF agents, which is kind of paradoxical and ironic because those agents are being used in treatment of uveitis, but you have to be aware that sometimes they actually can cause paradoxical reaction and new onset of uveitis. Looking at the treatment choices that we use in our clinic, so the most, I divided them in DMARDs with the traditional synthetic immunosuppressant and biologic agents. So of course, most of the patients are started with the DMARDs, which is a second-line therapy, and majority of our patients have been tried or currently receiving methotrexate. And I totally agree that mycophenolate mofetil is a very effective and agent that could be widely used in other parts of the world. Unfortunately, access to that medication is limited by its cost, and in most cases is prohibited by the cost of the medication. So most of our patients are using methotrexate, 43 of them using azathioprine, 32 cyclosporin, and we have like very limited number of patients on unchelating agents like cyclophosphamide. And you have to remember that some of those patients are on combinational therapies, so it's not one agent at the time, and some of them have been tried on one and then moved to another one, to third one. So they're not like individual patients, there are overlaps. In terms of experience with biologic therapies, we have 36 patients on adalimumab, which is Humira, and some of those patients are being on the medication not necessarily for uveitis. They could be the therapy could be initiated for treatment of rheumatological diseases or sometimes inflammatory bowel disease, which have significant overlap with uveitis. But those drugs also provide benefit for their primary disease as well as for treatment of their ocular inflammation. We have 7 patients on infliximab, 6 patients on rituximab, and other biologics, 5 patients. Okay, so I'm just going to skip. That's my presentation. I just wanted to have a couple of slides talking about particular cases and underlying the complexity of those conditions and benefit of multidisciplinary care team. But we're going to stop right now.
Thanks very much.